usually first thing I get asked is, what is it? And people go, well, I don't really know. My first boss said to me, it's whatever I tell you it is. One of my colleagues basically said, if I don't know what it is, then it must be advanced. And I was just like, well, actually, it's really quite simple, and people think it's really complicated. So what it is basically all the things that our expert panel of speakers have had today have gone through, all the kind of usual stuff, you know, tablets, pharyngects, infusions, psychological support, devices, etc., etc. And when you've tried all that stuff and your patient's still not right, and you think, well, they're not doing very well here, then you've got to think, well, what's the step beyond that? And that's effectively what advanced heart failure therapies are. And so what we're really talking about is transplantation and any form of mechanical device that improves or supports the circulatory system in some way. So it's not something that's funded in the usual way. It's centrally funded by NHS England, and it's not something that you have a right to. So you'll get lots of patients saying, you know, I've got a right to this and I've got a right to that. We've all had that conversation at some point. There is no right to transplantation or access to advanced heart failure therapy. It's a gift from the donor to the recipient, and that's all it is. Like, you know, giving vouchers at Christmas, except it's just a really good Christmas present. And when you think about it, well, how do you decide, you know, who gets this gift and who doesn't? And that's why the transplant MDT becomes very important. And everything I'm going to kind of really touch upon is just an extension of everything that's already been mentioned this morning. So Stuart talked about the kind of impact of MDT. It's effectively the same thing, but you're just talking about a slightly different therapy. So the MDT then decides suitability and benefit, and obviously look at the bulk of either absolute contraindications or those who have got a multitude of perhaps relative contraindications, and therefore who's going to likely get most benefit. So it is open to some subjectivity, but there is a fairly good kind of robust way of analysing that data so that you know that the best people for it are most likely to receive that treatment. If you've ever been to Manchester, I'm sure you've all been to Manchester at some point. Maybe not in the last 12 months, but it is still there, I'm told. This photograph was taken. I thought it must have been Photoshopped, because I've been to Wythenshawe thousands of times. It's never looked like that. I was like, it's got a blue sky. It's like, well, anyway, so that's what the front door looks like if you're looking for it. It's down there. So our local transplant centre is in Manchester, and University Hospital South Manchester, or Wythenshawe as we all know it to be. Many of us have been there, worked there in some way, trained there or so forth, and that's where this rabble of folk that I know quite well, we were all basically incarcerated there for years together on the training programme. So Manchester's a very important place to us as when we were trainees there, and we still have colleagues there that we know well. It's a very busy place. It's one of 6 transplant centres in the UK. It's performed an enormous amount of transplants now. It's officially the 2nd biggest transplant centre in the UK, and it's probably, in my view, it's probably the #1 performing centre, but you could argue that with the guys with Papworth, but it's right up there. You won't necessarily get a better opinion anywhere. More advancements in advanced heart failure as there is in every other aspect of heart failure. DCD donation, some of you might know what that is. That's dead, donor's cardiac dead as opposed to donor's brain dead. So you think, well, if the heart is dead and that's the reason for the patient dying, can you use that as a transplant? In some cases you can actually. So this was one of the innovations that came around in terms of supporting organs in the field when patients died in random places at bus stops and whatnot, using something called an OCS machine, which is an organ care support system by which you can keep the organs healthy and happy for as long as you can, whilst you then procure those organs to then gift them to someone else who might need them. Additionally, they offer the full gambit of everything you need, so long-term, short-term, durable stuff, you know, implantable stuff, percutaneous things, ECMO. And just to kind of put it in some sort of context, they are a secondary care service, the same as every other service, so they offer the usual bells and whistles to their local community, the same as anybody else. So they have an acute coronary care unit. It has 10 beds, and that's got to deal with the TAVIs, the primary PCIs, and all the rest of it. And that's where pre-transplant patients will go. If you transfer one of your patients to there, that's where they go. So you've got to fight to get one of those beds in there before they get to the post-transplant bit after it's all finished. So it's a busy place. This is just a slide just to kind of say, well, who can have one? Well, potentially there are enormous number of indications. This is clearly not an exhaustive list, but if you think, well, it's not ischemic or it's not this normal kind of heart failure problem, there's tons of reasons why people might be evaluated, so don't rule things out. Importantly, I would hark back to what's probably been said 2 or 3 times already, that age is a really important thing when I think looking at patients on their own. I've seen guys that are 17-year-olds who've got dilated cardiomyopathy who are really, really sick, 26-year-olds with desmoplaque and cardiomyopathies, you know, the weird and wonderful stuff that some of them look really, really well for ages, and they'd be traditionally labelled as NYHA1 and they wouldn't get assessed, but actually it doesn't take much for them to really end up doing very badly. And they often, kind of going back to the patient that we saw at the beginning, they often get misdiagnosed on a number of occasions before they finally get the right label for them that allows them to get the access to the treatment that they need. So I would always say, beware of the apparently well younger patient, because the physiology is so different from older people with such redundancy in that physiological system that they will adapt for so long and then they'll fall off their perch. So they'll go from NYHA1 to NYHA4 in about a fortnight, rather than your kind of slow plane landing car crash thing that you've seen with all the bumps and stuff that everyone, that slide's been used like 1 trillion times, hasn't it? So yeah, don't discount anything. Always have a chat with people if you're not sure, should it be considered. Take everyone on their own merit. So I'm told that these 2 fellas have both got the same cardiac output, so you can imagine that obviously that's not good for one of them at least. So always think, what's actually going on for this individual? I think Archie touched upon it expertly. I would always say, try where possible to understand the mechanism of the problem. A laminar cardiomyopathy is an absolute classic. So if someone says, well, what's wrong with that patient? Well, you say, oh, they've got a DCM. And I'd say, that's Roy Walker's catchphrase. You know, watching telly back in the 80s, I was like, well, let's just say what you see, isn't it? It's just a descriptive terminology. It says the heart's big, it's in the heart somewhere, and it's not right. It doesn't actually say much more than that, does it? It doesn't tell you how you got there, what the mechanism of the injury is as to why the heart's become in that phenotype, in offering that physiology. So Lamin being a great example of it, they'll have complete heart block on occasions, but they'll have a very high sudden cardiac death risk, estimated around about 50% at 5 years, whereas you're someone who's got a bit of a sluggish heart, who's 70, who's got complete heart block, might just need a Brady pacemaker, because the reason for them ending up with that problem is entirely different mechanism. So understanding why is important, not only for the heart and their risk, but also what else might be involved. What Archie touched upon, you know, you get your ICC problems, is there going to be liver problems, kidney problems, neurological difficulties, etc., etc. So it's important to build up a picture to then understand how they got there and then say, well, how are they now? Are they too good or are they too bad? So people who are like advanced heart failure are basically failed surgeons. Will tell you all the time, no, they're too good. They're too good. Go away. They're too good. Give a bit more DAPA. Try a bit more of that Entresto stuff. You know, all the stuff we love. Then you'll come back and go, I've done all that, doc. What do you think now? You go, no, they're too bad now. Sorry. That does happen. It is a very narrow window of opportunity, but it's important to keep doing what you can to do all the right things, but early assessment's important. So usually things like cardiopulmonary exercise testing, the utilization of your biomarkers that you use, CMR to understand mechanism, group discussions with people, device consultants, and so forth. The reason I say that's really important, because the first thing that sprung to mind when writing the talk was things like Marfan conditions, aortopathies, connective tissue diseases, because they might have a bad heart, they might have bad AR, the ventricle might be all baggy and big and poorly, but when you put a new heart behind that, it's like putting a new car engine in an old banger. You rev that pedal down and the whole thing falls apart. That's exactly what happens to people with aortopathies and connective tissue diseases like that. Get a nice new ventricle in there, give them a whole pile of shear stress through that aorta, and it tears apart. So understanding why is essential to knowing whether you should or you shouldn't do a thing. Initial things, everyone's all kind of come across this. We've all seen people with poorly kidneys, poorly tummies, poorly livers, heart rhythm problems, high blood pressure in the lungs. That's the kind of common stuff we see, and it's then trying to, where we can, unify the approach as to how we get over that initial insult in the kind of secondary and sometimes the primary care setting. But we all do things a little bit differently depending on what hospital you go to, so that's the kind of first hurdle to try and overcome. But always what we're trying to do with advanced heart failure therapy is not deal with what you've got in front of you, it's the anticipation of what you think you might have in 4 weeks, 6 months, and so forth, and planning for what do you do then. And that's why we think about vascular access, thrombosis. If they get a transplant and they're successful and they do well, they're going to need biopsies. How do you get your biopsy needle to the heart? How are you going to get in there? How are you going to get that piece of tissue? It's essential in what's and what's going on for them. So you need to be able to do that. But other things that some people here are really good at and some of us maybe aren't as good at, depending on how you feel about that. But managing expectations, managing discussions, telling them up front what's going to happen next, and so on and so forth. So potential barriers, there's a ton of them. But again, that's the word, it's potential. You've got to, and that's why I never really found this stuff that scary where some people do, because it's effectively general medicine. When you think about it, it's just GIM plus. So you're looking at all the bits, you're looking at the diabetes, you're looking at the height, the weight, the BMI, you know, have they had a massive stroke, you know, what else is holding them back, and then looking at the suitability. So you've got to kind of put all this stuff together, and some of it might seem a bit controversial and some of it less so, but it's really enforcing and enhancing that holistic view of patient care. That's really what it's actually getting at. So when we look at this, everyone loves an NYHA score, everyone's really familiar with that. This is basically an NYHA score plus. It just says it's the same thing. So Intermacs is basically the Interagency Register of Mechanical Assisted Circulatory Support, so that's what Intermacs stands for. And it basically says if you're used to NYHA 3, then it's down at number 7. So it's basically a 9 to 1 score. 1 means you're about to die, and 9 means you're probably fine, generally speaking. So we kind of start to get people around about this stage. Hopefully you don't find them at their first presentation on stage 1, because they've probably not got very long to go unless you do something very, very quickly. So once they start to do really badly with all the bits that you've done, you find that at some point you make an assessment and then say they need to go on inotropic support. And yeah, there is no prognostic benefit to inotropic support, because you're talking about what happens at 12 months. Well, I can tell you what the outcome will be should you not offer it when you should, and everyone knows what the answer to that's going to be. So we try and get them stable on inotropes, and then try and find ourselves some more time to work out why things happened, why things got to that way, and do all the usual bits we've said, and then discuss these things as a group. And sometimes that's not enough. Sometimes they start to slide off the cliff again, despite being on inotropes that once were good, were creating stability, and yet that progression is very aggressive and very rapid, and so they're still going downhill despite that. So that's Intermacs 2, sliding on inotropes, and obviously crash and burn needs no explanation. But once you get to Intermacs from 3 to 2, that's when you start to think they're going to need mechanical support. They're going to need more than you can offer with infusions and pills and so forth to keep them alive, essentially. This is what I do. The reason I do that is because it's what my boss told me to do. And very rarely do I just say, oh, he told me to. But to be fair, it works really well. There's many different ways to offer inotropic support, and the drug choice and the dose of administration. And many patients get noradrenaline and other catecholaminergic drugs and so forth. But this has been found generally in kind of adult transplant, which is a bit of a pilfer from pediatrics actually, to offer the best benefit of RV and LV support without unduly increasing afterload. And it kind of tends to offer the best balance in most things. So I won't dwell on that too long. This is my favourite bit. It's the bit that interventionalists absolutely hate, which is probably why I love it so much. So if you ask anybody in the room, do balloon pumps work? They'll say, no, balloon pumps are rubbish. This study says this, and the ESC are really unhappy with it, and you get a big red banner, which is probably why I like it, because it's always nice to do the thing, press the red button you're not supposed to, isn't it? And I completely agree with the evidence. So before I sound too controversial, I do agree with the ESC and everybody else who says balloon pumps are bad. If you're talking about people with acute cardiogenic shock, so heaven forbid one of you goes out there and smells the coffee and then has a heart attack, balloon pumps probably won't help you much if you end up in cardiogenic shock. What we see is that people who have heart failure, like our patients that were speaking this morning, someone's had that for years, on lots of medication, stabilized, well adapted, who's someone who's become basically accustomed to a low cardiac output state, where they might have a cardiac index of 2, it might be less. They're living off a cardiac output that's really low, and their whole body physiology adapts and changes to manage on that. The reason we think balloon pumps are bad is because it offers you about 500 mils extra cardiac output a minute, when if you think about normal cardiac output being 5 or 6 litres, as a percentage increase, it's very poor, isn't it? It's maybe 5 or 10% extra on top. So that's why the difference isn't helpful. But you've got all the risks associated with implanting that device, which are not inconsequential. But if you've got someone who lives off a cardiac output of 1 or 1.5 litres, adding an extra half in there could give you 25 to 50% increase in output in that time. So in that well-adapted, then decompensated patient who ends up in this situation, balloon pumps can be helpful. So it's just trying to give you an overview of some of the things you think, well, they're at the end of the road. Well, what else could we do? Obviously, there are negatives. I've touched upon that, and you probably don't need to do too many things. But innovations, again, people are trying to do things differently. So in Manchester, we've kind of taken some of the generally they put up through the femoral approach, up through the leg, chopped it into a few bits, and then pushed it down the arm. So you've actually kind of adapted it, completely off license, of course, which is, again, one of the other attractive things about it. You can do things off license if it seems reasonable. And you can then walk around with your auxiliary balloon pumping, going to Costa and having a coffee, which I just think is amazing. I just love it. VADs, everyone goes, love a VAD, because it's generally quite a simple device. It's a beautiful piece of kit that seems very complex, but it's not. It's basically a pump. So I'm getting told to hurry up here. So basically a VAD takes blood out of your heart and it squirts it around your aorta because your pump's not doing anything meaningful. And you can find people in VADs with very good cardiac output who come in saying, I don't feel very well, and it's because they're in VF. And they've been walking around for days in VF because actually they don't need the pump to create any form of cardiac output. It's nice if they've got a bit of extra, but they don't actually need it. So they've become like proper bionic by then. They do have their own problems, obviously, let's get past that, but the problems mainly being with continuous flow VAD being you get arteriovenous malformations over a period of time because you're not getting pulsatility in some of those devices. The newer VADs do offer pulsatility to try and minimize that change in endothelial growth factor expression, and it mimics the alteration in shear stress that you should get with normal cardiac output. But still, these guys will be anticoagulated, and they might get AVMs, and then they're at higher risk of things like intracranial bleed. So it comes back to the very basics again of saying blood pressure management's really important, isn't it? Because they tend to get higher pressures. And then how do you find a blood pressure in someone who's got no pulse? There's a good question for you. If anyone knows the answer, I'll buy a cream egg. So there's obviously problems. People do really well with them, but the life expectancy with the VAD's probably about 4 years with a long-term durable VAD from when you implant it. So it's not bad, but it's not amazing. They do tend to gain a bit of weight, so we don't use them as bridges for people who are too breathless and overweight to try and get to transplantation, because the evidence is very strong that actually they gain weight, and it's usually because you've shifted all the duodenal edema out of the way and they start to absorb everything again properly, which again touches back on the other colleagues of saying things like iron deficiency is a major issue in these guys and Ferinject is really helpful. But the good things is your life expectancy, it's 4 years rather than 4 minutes, so that's pretty good, I think, when you look at it that way around. The quality of life can be enormous, and there's, sporting events and all sorts of things these guys go to and put most of us in the panel to shame, to be honest. I think the one thing I want to say about this slide was I'm swiftly trying to come to the end is that anemia is really common, isn't it? We all see that. And one thing I would say is one of your take-home messages is please don't nibble away at blood transfusion. It's a really bad idea. If you're going to give them blood, do it proper and do it one time. The reason I say that is because every time you give blood, you all know that you will get antibody induction, and you're going to create a problem there, because if you think, well, I've got to match a new heart to this person, every time you give blood, you're making the matching more challenging by creating more antibody problems by which they may not be matched. And the evidence is actually very good that, say you need to give someone 8 units of blood, if you give them 8 individual units, transfusions, they get far more antibody induction than if you just give 8 units. So it's not about how much you give, it's about how many intervals you've given of blood transfusion actually infers that change. People will say this, I've got a heart transplant, I'll get a normal life now. Sadly, it's not true. You swap one sort of lot of disaster for another lot of disaster type of thing. You get about 12 years life expectancy. It's 3 times that of a VAD, which is really good. But again, if you're 35, you get 12 extra years, or if you're 17 and you get 12 extra years, it's not the panacea of everything you think it's going to be. You've got a lifetime of biopsy, of anti-rejection therapy potentially, biopsies for quite a bit, massive increased risk in skin cancer and other cancers as well because of that, osteoporosis, diabetes, and then people want to have another heart again, don't they? Especially when they've had a heart done maybe as a 5 or a 6-year-old and they come to adult medicine in their 20s and say, GOS told me I could get another one. And again, you're back to patient and family interactions, expectation management. So that's why I said a lot of it is general medicine. I think that's pretty much me finished. But it is general medicine. It's an extension of that. It's common sense, but it's doing the very basic things very, very well, but all together as a team. So thanks very much for listening.